So I have the experience of going third, so you may notice some overlap in some of the things that I say in relation to what you've already heard tonight. But needless to say, like Edward, I'm certainly feeling a little nervous being here tonight. This is a large crowd, and so you'd understand that I'm also feeling a lot of those indicators of nervousness. You know, my heart's been beating pretty quickly for a little while now, and my breathing's a bit constricted. And I'm also kind of scanning your faces and your body language for signs of a threat. And so one of the ways that I would try to regulate this in my own body is through a bit of movement and through trying to deepen and slow my own breath to try and calm that nervous reaction. Okay? So we know that through the concept of interoception, if we're better able to recognize and attend to our own physical and psychological experiences, then we may be better able to recognize and attend to those experiences in other people. So another way of saying that is if we're able to notice and regulate ourselves, then this might actually make us more empathetic. So the other thing that I would try to do to regulate myself is that while I'm looking at you for signs of a social threat, I'll also be trying to activate your social engagement system. I'll be trying to get some eye contact with you, or maybe get you to mirror some of my smiles or my facial expressions, and get you to form kind of a bit of a relationship with me. And so while I'm looking for a sign of threat, I'm also trying to form a connection. I'll be trying to get that mirroring, because we know that the social engagement system, the dynamic social engagement system, is absolutely essential in any type of regulation, and certainly then in any type of healing. Oops, I went too far. All right, let's try this again. Okay, so I want to take this opportunity to introduce myself and explain a little bit about where I'm coming from. So I'm a social worker by training. I'm not a neuroscientist. I don't claim to be one. And I currently work, as it was said in my introduction, in a concurrent disorders outreach team. But my clinical interest in trauma, and in this topic more specifically, sort of the social-relational system, started about 10 years ago when I was a new social worker. I was working in downtown Eastside Vancouver, and I was working in a program that worked with women in that neighborhood who had experienced violence. So most of it was domestic violence and sexual assault, but virtually all my clients had experienced multiple relational violences throughout their lifespan. So my training as a social worker taught me to see people and their problems in the context of their social identities, their relationships, and their access to power and resources, or lack thereof. So through this lens, the violence that my clients were experiencing was a direct result of systems of inequality and of a misuse of power and control by partners and strangers and other systems they were interacting with. So this helped explain the context of the trauma, but it didn't explain everything that I was witnessing. I would see things like extreme emotion and anxiety, frozen faces of dissociation, very childlike behavior at times, high levels of substance use, and a near compulsive urge to seek love and connection from the people who had so seriously harmed them. So I felt, needless to say, I felt kind of ill-equipped to attend to what I was witnessing completely. So I tried to do some research on what the best practices were for working with trauma, and more specifically for working with the kinds of chronically traumatized clients that I was seeing. And so much of what I came across sort of advised the use of cognitive behavioral therapy, CBT, as sort of the gold standard of treatment. And it's a very valid treatment, but it didn't sit quite right with what I was seeing. So much of the CBT research that I was coming across had very rigorous exclusion criteria. So things like chronic suicidality or a recent suicide attempt, active substance use, co-occurring psychotic or mood disorders, homelessness, domestic violence, which means most of my clients would have been excluded from the studies. The other thing that I noticed in many of the studies was that the attrition rates, particularly for women who had experienced sexualized violence, were very high. So the attrition rates are the dropout rates. So folks who completed the treatments, they had some success, but a significant percentage could not tolerate or complete the treatment. When I found research on CBT for PTSD, or rather when I found research on the efficacy of CBT for complex trauma and substance use disorders in women who are also living with co-occurring marginalizations like racism and poverty, CBT wasn't clinically significant. So what this started to show me was that relational wounds need relational treatments, right? So this leads me to something else that I often observed when I was working with my clients in the downtown east side, was that sometimes when I asked them, like at the end of our work together, like what had been really helpful about our time, they wouldn't say things that I thought they would say. Like they wouldn't tell me, Leslie, you had this wonderful explanation of a gendered analysis of violence, or you'd employed this really skillful cognitive intervention. They would say things like, your eyes are kind, or your voice is soft and not too fast, or when I tell you about things that have happened to me, you do this, right? So what this started to show me is that there's a relational component to the work that we do that may be the most powerful aspect of what we do. So this is what I went on to research more on and eventually to publish on, was this model of working for trauma that attended to both the context that it occurred in, because we need to remember that the things that made people vulnerable to relational traumas in the first place don't suddenly go away once the trauma has ended, right? Things like poverty and gender and race, right? And the other thing it helped me learn more about was that what we do in a therapeutic relationship matters not only from a psychological perspective in terms of modeling things like boundaries and trust, but from a physiological level. What we do with our nervous system matters so much because we are co-regulating the nervous systems of clients through that relationship. And if we can show up in a place of social engagement and connection and empathy and our own regulation, and we can maybe get the client to mirror that with us for a few moments, then we've hit the window where some healing can begin to happen. There we go, okay. So Edward's slide was much more comprehensive than mine. We'll roll with this one. So when I say that relationship matters on a physiological level, what I'm referring to is, what I'm drawing from, or I should say, is a lot of the work of Dr. Stephen Porges as well. So an American psychiatrist, he made breakthroughs in the way that we really understand the autonomic nervous system when he proposed the polyvagal theory. So polyvagal theory focuses on the role of the vagus nerve in autonomic nervous system function. And so the vagus nerve essentially runs from the brainstem down the length of the spine, and it connects to many of the major organs in the body. And it's primarily involved in the parasympathetic nervous system function. So this was traditionally thought of as our rest and digest kind of function. So Dr. Porges' theory was that the parasympathetic nervous system actually has these two branches. So the one branch was the ventral vagal branch. This is our more modern, mammalian, human kind of branch of the nervous system. And you can think of it as kind of from the diaphragm up. So it regulates more things like breathing, but also the muscles in our face, so our facial expressions. Our eyes, so the gaze, the way we look at people. The pitch and tone of our voice. And our inner ear, which attunes to the pitch and tone of other people's voices. So our social engagement system. And so the theory was that in response to relational threats, our first reaction is to try and engage this branch of the nervous system, to try and form a connection, to try and co-regulate the distress in us or the distress in another person by sending these signals back and forth that we are safe to be around. So if this is successful, then we can enter into that state of rest and digest. So rest and digest most optimally occurs after an experience of safe connection. Okay? So if you think about it, developmentally, we can't actually learn to feel safe and regulated in ourselves until we've had the experience of being safely co-regulated with another person. Children don't have that capacity, right? So many of the clients that I was seeing had never experienced this kind of social safety. So asking them to self-regulate before they had the experience of co-regulating was an extremely challenging request. Self-regulation may be a therapeutic goal, eventually to work towards, but healing from trauma can't happen in isolation. Since trauma survivors have not had that experience of feeling safe in the presence of another person, the ventral vagal branch of their nervous system may be underdeveloped or not working to full capacity. So if our social engagement system, going back to polyvagal theory, if our social engagement system is ineffective at addressing a relational threat, then we'll move more into that spinal sympathetic activation, sort of our fight or flight response. And I won't spend too much time on that because I'm assuming sort of a shared level of understanding. But essentially the fight or flight response activates the body. And the important thing to know is we begin to withdraw connection at that point because we need to see people as more threatening. And we begin to withdraw empathy at that point because we need to potentially be able to fight or abandon the person, right? So if the threat is too big for our internal resources, or if it goes on too long, like in the case of chronic relational stress, then folks will go into, the parasympathetic nervous system will activate again, rather, to this time begin to conserve energy and to minimize the damage, the potential damage, psychologically and physically, of the trauma. So the dorsal vagal branch is our most primitive reptilian survival response. Our digestion slows down, which affects our neurotransmitter production. Our muscle tone reduces, and our affect will flatten because we're so far out of the social engagement branch, and at this point, really, social connection isn't going to help us anymore. So we begin to collapse and dissociate in order to survive. And this is the place that many trauma survivors will go to and get stuck. And this is a profoundly difficult place to come back out of. So we need to attend to the fact in our work that the therapeutic work that might happen if someone is in the sympathetic activation or in the dorsal branch of their nervous system may have a minimal impact on fully integrating new relational experiences. If we don't prioritize and activating clients back into a social engagement branch of the autonomic nervous system, our interventions may be incomplete. And the way that we engage this is through sending signals with our own social engagement system, our own ventral branch that we are safe to be around. So things like our voice, the pitch, the intonation, the way we look at people, the way we mirror facial expressions, the way we hold our body and our breath rate. These are all signs to our level of social safety. And the hope is that this ventral activation may begin to get mirrored by the client and momentarily increase the capacity and function of their ventral vagal branch. So if we're showing up to therapeutic relationships in an anxious or an activated or an overly authoritative way, then we might miss that window where we could actually create some meaningful healing with trauma survivors. So Dr. Gordon Neufeld says, we don't learn from people we don't like. So I'm sure you can think of examples of this in your own life. But this is important because in the concept of trauma treatment, this is important because a lot of treatment includes an element of psychoeducation. And psychoeducation is very valuable. I use it a lot in my own practice. But again, we need to be attending to the social engagement systems of trauma survivors before we're delivering any education or treatment planning or information or things like that. So things like softening our gaze, slowing our own breathing, getting some mirroring in the facial expressions, getting some rhythm in the body to be mirrored. These might be signs of engagements. Things like swallowing or yawning or sighing may also be signs that there's starting to be a shift back into the parasympathetic branch without going into a collapse response. So I'll invite you to consider that from a polyvagal perspective, rapport is not something that we get and then we have it, right? Rapport is a dynamic, co-regulating process that we must be attending to moment in our work. So something else to be mindful of is that on the cusp of social engagement and sympathetic activation, looking at my very basic little diagram here, there's this mid-state where people's nervous systems can kind of be in relationship and kind of still be primed for a threat. And this state may be known as play or as competition, right? So this allows people to, before people can fully come down from a fight or flight response and into a full intimate kind of connection, they may pass through this kind of play state. So anyone who's worked with street and trench populations like I have for most of my career will be really familiar with this kind of level of like banter and testing and joking and playfulness that occurs in these type of relationships. And I wouldn't undervalue this, because these are folks who may never make their way into a 1-hour therapy session, right? But these are still attempts at connection and co-regulation that still let people have a foot in the fight or flight survival system that they need to survive in chronic stressful situations. So finally, when we talk about working with marginalized and complex trauma survivors, another way that we communicate our social safety, I'll propose this to you, in addition to the nonverbal cues that I've been talking about a lot, is through a recognition and a validation that for not all people, trauma has a clean beginning, middle, and end, right? So we have to recognize that people continue to exist in relationships and systems of power and inequality that continue to profoundly affect them, either as a reminder of the trauma or as a traumatizing experience itself. So through this lens, we may consider that a lack of success in therapy is not a product of characterological deficit or lack of motivation, but rather that after our interactions with clients, they go out and exist in a reality that is profoundly threatening. And it is continuing to overwhelm their internal resources. So focusing too much on trying to teach skills to someone who continues to be triggered not only by their internal symptoms, but by relationships and social experiences that replicate the trauma may be limited. And this is what I came across in my research. So for one, the nervous system won't be in a place to engage new learning very well. But I'll also invite you to consider that one of the ways that we communicate our level of social safety is through recognizing context that perpetuates trauma. And if we're unable to attend with our clients to the why did this happen, beyond individual pathology or misfortune, then we risk positioning ourselves as unempathetic and, from a vagal perspective, unsafe. So don't get me wrong, we can teach very valuable skills in practice. I do this a lot as well. Things like I use a lot of breath work, I teach yoga, right? DBT skills. These are wonderful skills for reducing overall stress reactivity. But ultimately, relational wounds need relational treatments in order for the nervous system to heal. So in many ways, perhaps the experience of teaching a skill and learning and practicing and being in that experience together may actually be where the value lies and not in the skill itself. So ultimately, our role as clinicians who work with trauma survivors is not only to teach people how to endure terribly stressful situations or to teach people to think differently about their terribly stressful situations. Our role is to attend to the profound loss of connection inherent in interpersonal trauma by providing a corrective relational experience. And we do this with an awareness of our own bodies, our reactions, how we show up and send social engagement signals. And we do this with an awareness of our power and how we can use that power to co-regulate or to reenact threat in the systems of trauma survivors. And we do this by entering into a dialogue about the dynamics of power and inequality that allowed the trauma to occur and continue to occur towards clients and people who share identities with our clients. Right? Because when we attend to these dynamics in a really conscious kind of way, then we've hit this window where on a social, emotional, and physiological level, healing and regulating experiences can really deeply